This patient presented with severe temporomandibular joint and myofascial pain, headache, locking, restricted jaw function, and arthritis. She was initially managed by splint therapy, followed by maxillary and mandibular orthognathic surgery without TMJ surgery. This is her post-operative. This is a case of that I did with my mentor, Dr. Mara. It's one of his patients. The results showed demonstrated post-surgical results with very stable and no aggravation of the symptoms, and her TMJ symptoms improved after the surgery without opening her joint. So she was managed by conservative therapy. The next topic that's very interesting also is progressive alteration of the shape and size of the condyle, accompanied by a decrease in condylar mass, which is the definition of idiopathic condylar resorption. This can be self-limiting. It can have intermittent periods of remission. Sometimes it gets reactivated by orthodontic treatment or orthognathic surgery. The real etiology is unknown. However, there are some risk factors like rheumatoid arthritis, internal derangement, steroids, trauma, orthodontics, orthognathic. Typically, it's unknown. However, very interestingly, I think there's a few studies now that found estrogen receptors in the temporomandibular joints, and they found that women taking birth control pills, they had some association with idiopathic condylar resorption. It's very clear in the literature that it's more common in females. So this also strengthened the fact that there might be a hormonal component to this disease. How do we work up these patients? Serial clinical exam is the key. So you do a clinical examination at specific time intervals, and you follow the patient clinically and radiographically. Typically, the patient would report progressive mandibular retrusion. Sometimes they have TMJ symptoms, and many times they don't. Class 2 relationship, usually they have open bite if it's a bilateral case, and they would have asymmetry in cases of unilateral. Technetium 99 bone scan is useful to compare if the disease is active or if it's not active, and typically you want to compare the activity at the TMJ with the fourth lumbar spine, and if it's more than 2 standard deviations from that, then you would conclude that there's an increased activity at the joint. The treatment is controversial. Classically, it involves joint replacement with costochondral graft. However, the new research is directed toward 2 specific concepts. First, avoiding TMJ surgery completely with using splint stabilization and medical management, and there's a lot of research that's being done in that area, the use of medications to halt or reverse ICR. And then TMJ surgery, whether with disc repositioning or alloplastic replacement. Initial management should always include symptomatic treatment with conservative therapy. So if the patient comes, it's going to be one of 2 options. Either the patient is coming in a burnt out ICR, which means it's not active. And there's 2 ways of people managing this, or people think about this. Some recommend using maxillary surgery to close the open bite by posterior impaction and a camouflage genioplasty for chin projection. The disadvantage of this technique, prolonged treatment time, if you just wait for the disease to burn out, so that prolongs the treatment time. It has compromised aesthetic, and the class 2 relationship and the decreased posterior airway space persists, so it's not ideal. And also, the concept of avoiding mandibular surgery does not guarantee that this process is not going to get reactivated. So this patient, she is in her late teens. She presented with progressive mandibular retrusion, anterior open bite. She had TMJ pain. She did not have any limitation in her mouth opening. She reported clicking and popping in her joint, and she wanted to have treatment. We did radiographic analysis. You can see in her panoramic X-ray, it was very clear that she had joint resorption, and she had narrow posterior airway space. She had daytime somnolence, and she had a high score on episodic sleepiness score. So I would like to ask you guys, how would you manage this patient? So